Thank you, Jamie. So good afternoon, everyone. Our didactic topic for today is a journal club. There was I don't know if this was sent to me or if this was part of a question that had been brought up, but looking at the intersection between depression and a number of chronic medical conditions. And this was an article that I had came across that looks at that specifically, both why that may be a concern and how at least one particular cohort may be handling this. This was part of my attempt for Feel Good Friday. So if that tells you anything about what the results are going to be. And I am unable to move these slides forward. Hold on just a second. There we go. All right. From an objective perspective, we're just going to look through the article. So we're going to discuss the publication. We're going to talk a little bit about the methodology and what they looked at. There are a couple drawbacks from this. This really is kind of a larger look at depression care, so maybe a little bit more superficial than what we would hope for. But what that may mean in terms of clinical practice. So this is the citation. The PDF of the article is uploaded on the IACO site if you are interested. They included some data in the article, but as you see, it was published in 2017, and I wanted to look a little bit more recently at some of the depression data. So it is suggested that about 1 in 12 adults, at least in the United States, over the course of the past year, have met criteria for major depressive disorder. And this is from the 2021 National Survey on Drug Use and Health. It's expected that about 61% of those individuals who meet criteria for major depressive disorder are engaged in treatment. So we're not really reaching everybody who fits that criteria. And one particular subset of those patients are those who may have chronic medical health conditions. So it is estimated, depending on the cohorts that you look at, that potentially up to 1 in 5, so about 20% of folks who do have some chronic health conditions may meet criteria for major depressive disorder. So why is that cohort a little bit at a higher prevalence? Why are they more at risk? It's not really clear. I was looking for a good chicken or the egg picture to put in here, but I also received the invitation for our copyright presentation, so I opted not to use that one and use this graphic instead that I made. It's thought that they both contribute to each other. It's not really clear if one came first in all instances. For a number of the chronic health conditions, there may be stress associated with it. There may be some pain. There may be some discomfort. In some cases, there may be limitations, whether it be cognitive limitations, physical limitations, that may then contribute to the development of depressive symptoms. On the flip side, there is the possibility that some of the both physiologic and behavioral changes that are associated with major depressive disorder may then contribute to the development of or exacerbation of some of the chronic health conditions. There also is the possibility that for some of the health conditions, there may be a common etiology. Whether it be underlying inflammation, whether it be some other type of neurochemical abnormality or malfunction, that an individual is more or less sensitive to some of our neurotransmitters, which not only play a role in the brain, but also do additional signaling in other places. It's possible that that also may play a role. So it seems that they are pretty closely linked, which may be why we see that increase in prevalence in those patients who have chronic health conditions. Now, why is that a big deal? So yes, they are more likely to have it, but does that really make a difference? It's suggested that folks who have both chronic comorbid health conditions and depression may be at a higher risk for negative health consequences. So some of these consequences, again, this depends on the cohort, but they have been able to demonstrate that they tend to have an increased disability. So compared to someone who did not have depression and a chronic health condition, for example, cardiovascular disease, they may be, those that have both would have greater disability. They tend to have increased healthcare costs. They tend to have an increased risk for cardiac events, specifically in a post-MI population. But in general, for those who have any type of cardiovascular disease, they appear to be at a higher risk for mortality compared to their counterparts that don't also have depression. There also has been acknowledged to be a decrease in adherence to treatment, potentially not following through in treatment or dropping out of treatment. We can see a decreased quality of life as well as decreased rehabilitation. So, for example, in some of those cardiovascular patients, the ability to get back to their level of functionality that they had prior to their cardiovascular event appears to be diminished in patients who also have symptoms of depression. So in an effort to try to improve clinical outcomes, this appears to be a good target population. So a population where we really want to make sure they're getting access to care. So these authors specifically wanted to look at depression care. So what were the depression care patterns among patients who had just depression and those who had specific chronic health conditions? So how did they do this? Now, these investigators were Canadian. They did a retrospective review of administrative health records in the province of British Columbia. So they do have nationalized healthcare. They have access to a relatively comprehensive database. It wasn't 100%, it was only 96%. There are a handful of individuals who, for a variety of reasons, are protected and kept out of the general database. So they were able to access about 96% of the individuals who live and receive care in British Columbia. They identified patients who were diagnosed with depression between January 1st and December 31st of 2012. And they evaluated the health records. So they didn't only want to look at the year that they had the diagnosis of depression, they also looked at the year prior and the year after. So they really wanted a snapshot of how many services these individuals were utilizing to be able to make that comparison. And I've said comorbid chronic health conditions, but not told you exactly what they were. It could be a number of things. For the purposes of this study, they specifically included asthma, cerebrovascular disease, chronic kidney disease, chronic obstructive pulmonary disease, congestive heart failure, diabetes mellitus. They did not specify if it was one or two, so it appeared to be both, and ischemic heart disease. So that's how they were doing it. What they specifically wanted to look at was the 12-month use of depression-related health services. So the primary outcome that they were looking at was patients who received counseling or psychotherapy, those who received antidepressant therapy, how many visits they got for the psychotherapy or counseling sessions, the proportion of days they were on antidepressant therapy. So just because you are prescribed an antidepressant doesn't mean that you take it all of the time. So did they receive enough medicine to cover that period of time? But then they wanted to look at some other factors. So how many general practice visits did they have with their primary care provider? So were they requiring more treatment? How many mental health visits did they have? And what was the continuity? So were they continuing to see the same provider or not? Did they have a bunch of different providers that were helping to have those services? So from a statistical analysis standpoint, they used a generalized linear model. They adjusted for age, income, place of residence, as well as sex. So there are some places in British Columbia that are a bit more rural than other places. And they did create 3 categories, so rural, suburban, and urban areas for that comparison. They calculated odds ratios for those who had medical conditions compared to those who did not. So what did they find? Well, they had a fairly robust sample that they were able to evaluate. There was a total of 105,476 records that they were able to analyze. Of those who had depression, there were more than 66% that were female. Most of the most prevalent age group was between 46 and 55 years old, with the next two being just on either side of that. So 36 to 45 and 56 to 65. So while they were 18 and older, these really were the most prevalent age distributions. For patients who had been diagnosed with depression across the board, it was more likely that they were on the lower end of the socioeconomic status. They were in the lowest two categories financially, and they were more likely to live in an urban area. So when they looked at depression treatment, so all of the individuals that they included had a diagnosis of depression. And they looked at, so did they receive any treatment at all? And I'll be honest, I was pretty impressed with 91%. That was way more than what I was expecting. So 91% of those who were diagnosed with depression got some type of treatment. 45% received both counseling or psychotherapy and an antidepressant. Just under 60% received psychotherapy or counseling, and then about 76% received some type of antidepressant therapy. So it was relatively robust. More than half and up to 2/3 of those patients were receiving psychotherapy, counseling, and antidepressants specifically. So it looked like overall they were doing kind of a better job than those numbers I told you initially. When they looked at the visits per year, there was a slight difference. On average, there were 12 visits per year for the general practitioner, although those who had chronic comorbid conditions had significantly more visits per year than those who just had depression. So for those who just had depression, they were on average about 10 visits per year, and those who had chronic health conditions really were between 15 and 22 visits per year. So the depression only really pulled that average of visits down. So if they had a medical condition, they were seeing their primary care provider much more frequently, which I guess shouldn't be too much of a surprise. When they looked at the mental health visits, there wasn't a difference between the groups, surprisingly. So with those who had just depression, as well as those who had medical conditions, it was between 3 and 5 visits per year with an average of 4. So we really saw a lot more variability with just their general practice visits than we did with their mental health visits. Overall, they were fairly likely for the mental health visits to continue with their same provider. So there may be a lot of confounding reasons for that. Potentially, if somebody is prescribing medication or following someone for a mental health condition, they're more likely to continue to see them, as opposed to for the general care visits, their medical visits, potentially they were being seen by other providers other than their general provider. So it was the criteria, it was 0 to 1. So it was about how frequently they continued to see the same provider. So it's not a huge difference, but it was more significant that they consistently saw them for the mental health conditions. In looking at the counseling sessions, as you can see, the average was about 3 counseling sessions per year. It did vary. I think this calls into question the severity of depression for some of these individuals if they're being seen every 4 months, as opposed to being seen monthly or even more frequently. And there was a little bit of a difference between some of the conditions. So chronic kidney disease, asthma, and ischemic heart disease were a little bit more frequent than those who had just depression alone. Although we also see cerebrovascular disease and congestive heart failure they were less likely to have as many counseling sessions as those who just had depression alone. To be fair, when we round these, it goes to 3 or 4. So from a clinically significant standpoint, I'm not sure the clinical significance is there, but it is an interesting finding that there was a bit of a difference between some of these conditions. When they looked at the proportion of drug days covered for antidepressants, so did they receive enough medicine to cover 180 days or to cover the full year, the 365 days? We see that on average for 180 days, it was about 81%. So about 81% of the time, those patients had enough medicine to get them through. So yes, there was a little bit of potential non-adherence or gaps in coverage, but it was maybe a little less than at least what I was expecting. For the year data, the average was about 0.76. So 76% of the time they had enough medication to get all the way through. As you can see from the 180 day and the 365, they were pretty similar in the amount of medication that they got. So they didn't see too much of a difference in folks not taking their medication, even if they were prescribed. So let's look at a couple of the other pieces. So as I told you, they did look at the odds ratio. So in general, we saw that their counseling sessions were about 3. So for those who were engaged in counseling, they got pretty similar between 3 and 4 sessions for the year. But when they looked based on disease state, so diabetes, congestive heart failure, COPD, CKD, asthma, cerebrovascular disease, and ischemic heart disease, if they had most of those chronic conditions compared to only having depression, they were more likely to be referred to have psychotherapy and to be engaged in counseling. So cerebrovascular disease, our orange bar, was the only one that was no different than those that had depression alone. So it did seem that counseling or psychotherapy was pretty frequently recommended for patients who had these chronic health conditions. We did not see a difference between the antidepressants. The folks who were engaged with general visits, as we saw numerically, there was a little bit of a shift where those who had medical conditions were more likely to have general practice visits, but between the diagnoses, we did not see a difference. So compared to depression alone, if you had a medical condition, you were more likely to have more general visits, but it didn't depend on that condition that you had. It looked pretty even across the board. When they looked at the mental health visits in general, interestingly, the patients who had diabetes were less likely to have mental health visits, so they were on the lower end. And those who had COPD and asthma were more likely, so they were on the higher end with the number of mental health visits that they had. 2 of the reasons that they suggested that that may have happened, one is potentially some of the depressive symptoms may have been thought to be due to diabetes. So it became more of a medical visit as opposed to a mental health visit. And kind of on the flip side, for those who had respiratory issues, it's possible that some of those respiratory issues were translated into mental health symptoms, why they had more mental health appointments than general practice appointments. So in terms of discussion and consideration, they actually did a fairly good job. So individuals with chronic health conditions tended to be engaged with more counseling sessions and had more general health visits than those that had diabetes or that had depression alone, excuse me. So maybe we want to make sure that we're taking care of some of those folks who may only present with depression and not have some of these more severe medical conditions. We didn't see a difference between the mental health visits or the antidepressant groups. To be fair, it did not account for severity, as I had mentioned before. So we're not really sure how severe the depression was for any of these cohorts, nor did it include any of the efficacy data. So yes, they were more likely to have counseling or psychotherapy sessions, but on average, they were having 3 to 4 per year. So how effective were they in reducing the depressive symptoms? Same thing with the antidepressants, just because between 75 and 80% of the time they had their antidepressants, was that actually being effective in treating the depression? And did that result in better clinical outcomes? That data was not evaluated. So in terms of clinical impact, despite the fact that there is concern for increased negative consequences, at least in this cohort, individuals with depression and chronic medical conditions were receiving depression care a little bit more robustly than those who just had depression alone. Specifically, their general therapy appointments as well as the psychotherapy counseling. We do need some additional information to be able to see about the effectiveness and outcomes if there are potential target populations. There were quite a few suggestions within the paper that cerebrovascular disease population appears to be one of the populations that's less likely to be engaged in depression care. There were some concerns about the use of some of our antidepressants, specifically serotonergic antidepressants, which may thin the blood if they're already on blood thinners because of their cerebrovascular disease. Maybe they're less likely to get that. That's not what the data showed, but they did suggest that there was more hesitation in engaging those individuals in treatment. So likely there are some target populations we could look at, but overall it looks like that gap has closed at least a little bit for this population. So that's what I've got for today, and I will stop my share and turn things back over.